I'm talking about muscular anatomy. I will show you some cases of thrombectomy. Some of my colleagues here have referred these patients, and you can see, and I'm only going to show you the good ones, and I'm not going to show you complications, okay? But main idea for today is to bypass the middleman, okay? That's the radiologist. That's where I am. That's what I think we need to aim at. And don't tell your radiologist how you could tell them. I don't know. Anyway, so if you look at the flow to the brain, you have, so ignore me and I apologize if this is too basic for somebody, okay? But we need to start somewhere. So if you are happy with it, just tell me all of you are okay with anatomy, or you want me to go right from the basic, right? Is that okay? So when you look at anatomy, okay, and I'm an interventional radiologist, you look at the anterior circulation, you got a posterior circulation. So that's the first thing. Anterior circulation, you have the internal carotid artery, and you have a posterior circulation, you got a basilar artery. So let's remember that this is the main artery. In all you guys and we need to know from stroke point of view is basilar artery, internal carotid, middle cerebral artery, isn't it? That's all. How difficult can it get? Right? And that's what I'm going to keep repeating that. And then this is the circle of Willis. When you look at the anterior circulation, you've got internal carotid artery, anterior cerebral artery, and these two are connected by the ACOM. You've got a posterior communicating artery that connects posteriorly to the posterior cerebral, and you have the basilar, which is formed by the two vertebral arteries. So we're going to go right from the anatomy. I'm going to start from the arch, obviously, and then we're going to start this going through the anatomy, look at the vessels, then we go through each vessel one by one and reach the circle of Willis. So, assuming we all are students, and I'm taking, probably apologize that I'm taking to medical student days, but descending aorta, arch of aorta, and the ascending aorta, okay? And the why this is important, because all of us need to know, whenever you guys are going to practice, if you are looking for CTA, please include this. Why? Because if this is crap, and he's an 80-year-old, there's no point sending him to me, okay? Because if I'm going to take 2 hours to get into this artery, then it's no point, okay? So for us, technically, every time you're looking for CTA, you have to include the arch. Very important, arch, and then you got a big neck vessels, and obviously then you decide whether you got a right brachiocephalic, left common carotid, left vertebral artery. And you know these can vary, they can be connected, they can arise from each other. And so look at this one. So you have got the arch, so we're moving down from arch. We got the brachiocephalic here, we got a common carotid here, which will then divide into the external and the internal carotid. We got a brachiocephalic, internal memory artery, vertebral artery. Okay, on the left side again, you got this the left subclavian artery, and then you got a left vertebral artery. Again, so remember 3 big vessels coming from the top. One is the right side brachiocephalic, left common carotid, and left subclavian. When you do an angiogram, again you got exactly what you're going to see. Most of the people, can you see? Or is it okay? Okay, so you got an arch here, as you can see, and you can see one vessel which goes to the left. It's going to be the left carotid artery. The other one here is the left subclavian artery, and you can see the vertebral artery. Quite often you will see the vertebral artery here twist and turns around here as we get older. But that's the left carotid, left vertebral artery. On the right side, you've got a right brachiocephalic, which will then give you the vertebral artery here, which is coming off like that. And it's very important, these two arise opposite each other quite often. So it's a good marker. If you've got an internal memory, I remember when I was a trainee, I missed an internal memory artery aneurysm. And Ravi was next day, and Venkat was my colleague at the time. I told my consultant it's all normal, because obviously I missed the internal memory artery aneurysm. I was looking here. So vertebral artery across that, and that's the left common carotid artery. And again you can see the overlap, and it's very easy. The internal carotid artery is a bit bulky, it's a bit wide because you've got a carotid bulb there. So now we move on. When you got a common carotid artery, that will obviously divide into the internal and the external. And the internal carotid artery in this layer, in the neck, doesn't have any branches. So it's easy to recognize, and you can see that you have the external carotid artery, and you got a number of branches that will come, and you guys are not interested in that, are you? So neither am I. Okay, it's not in for stroke. So not interested. Sometimes you want to know it, because if you got a disease in the bifurcation, then you might want to put a stent there and then do a thrombectomy, and you just want to make sure that you're not covering, and you will cover, and it doesn't really matter, but you just want to make sure that you are covering it properly across the bifurcation. So now we move on from the external carotid, we'll just quick work, single slide, external carotid artery, look at that. The way to identify external carotid artery has got all these different branches. Why do I need to know this? Because for me, as an intervention is very important, because we all are born with connections of internal to external, right? And then they disappear. Well, they don't really disappear, they just don't work because brain decides that it wants only internal carotid artery, you know. So external carotid artery is important because when you have all these vessels, they all have got embryological connections with internal carotid artery. So when you play around as an interventionist in this field, we need to be very, very careful that you don't embolize because the internal carotid artery is here. Got that? And that's why it's very important to know. And there are different branches and we don't care. Most important, okay? Like I said, you got to really learn two arteries in my talk. So my talk is very easy. So you got the internal carotid artery. This is the petrous segment. And this is one of the locations quite often we get dissections in the petrous segment. And then you got a cavernous segment. As it comes around, it takes a turn, and you got segment 1, 2, 3, 4, 5, 6. It doesn't matter. You just say cavernous segment, supraclinar segment, and then you got one branch in the front, which is the ophthalmic, and then you got a PCOM and the anterior choroidal coming there. So again, just remember, cavernous segment, artery comes here. Where does the artery become intracranial? Where is the dural ring? The dural ring is where it's here, and I'll show you that. So if you look at that, you have the common carotid artery, internal petrous origin. As you come in, you are getting the cavernous segment, and just at this level, in the supraclinoid, as the carotid artery comes up and takes along the anterior clinoid, there is a dural ring, and that's where the artery becomes intracranial. And the first intracranial branch is the ophthalmic artery, correct? So it's a way you know that why do I need to know? Because when I do aneurysms, I need to know whether this aneurysm is intracranial or extracranial, okay? But from stroke point of view, do I need to know? Well, sometimes you want to be sure that when you get catheters across, where is the ophthalmic artery, where is the blockage? So sometimes it's useful for us. And then you can see on the lateral, you can see that. So we have so let's go through this quickly. You got a common carotid artery, vertical portion, the artery goes up and into the petrous, then it goes into the petrous here, then you get the petrous segment, which is the horizontal petrous segment, then you got a cavernous segment, and you got a cavernous sinus around it, that's where you can get caroticocavernous fasciculus, and as that it comes up, you got the ophthalmic segment, which is now intracranial segment, and then as we move up, you're going to get the supraclinoid coming up, and then you got the posterior communicating behind. Okay, and so we're going to now start talking about PCOM and the internal carotid artery. So again, you have the internal carotid artery. So remember I said the ophthalmic artery. I keep telling all the trainees, very important. When you have an MCA block, it's easy on the CT, you can see it. But when you're doing the angiogram, you have to sometimes find that branch. And it can be very tricky. Sometimes it looks because there are so many arteries. You might wonder, where is the block? The best way to know is this triangle. Okay? Always remember on a lateral view or on a CT scan, you have the anterior cerebral artery and all the MCA branches are filling into this triangle. When this triangle is empty, you know there is a branch missing. Okay? So when you don't see it, on the lateral, if you don't see it and you don't see much flow there, you know that you have to go and turn your CTA to find that branch. MCA can be tricky. M1 is okay. Once you go to M2, you have to look for it. So if you look at this one, internal carotid artery, the first branch behind here, as you can see, is the posterior communicating artery, which then will become a PCA. And then you got an anterior cerebral artery, and you got a middle cerebral artery here. So you can see that. And this one, you can see all these middle cerebral arteries are filling here. Okay? Everybody's happy with that? Am I going too fast? Is it okay? So let's move from the PCOM. I remember I told you there was the PCOM is the one which is the first one, and the next one is the anterior carotid artery. Why do we need to know anterior carotid artery? Because it's a very important artery. Small artery, big territory. And anterior choroidal is one artery. Everybody gets scared. I get an aneurysm in that location, I'm worried about it. The neurosurgeons don't like to clip it. Why? Because when you damage the anterior choroidal artery, you can get into trouble. And anterior choroidal artery is very important. It stays in a very much symbiotic relation or balance with the PCOM. So people will have different. Either you have a big PCOM and a small anterior choroidal, or you have a small anterior choroidal and a big PCOM. Again, for me, it's very important because when I treat one or other in territory, I know how much damage I'm going to do if there's going to be a damage. So remember always, the anterior choroidal is one of the two arteries most important in our body. Anterior choroidal and anterior cerebral artery, anterior spinal artery, because the damage, they are small arteries but big problems. So if you look at this one, this is the frontal projection. As you can see, you got an internal carotid artery, petrous segment, horizontal petrous segment, cavernous segment, supraclavicular, and you can see that internal carotid artery comes up, divides into two, into the anterior cerebral, middle cerebral. You got an M1, M2, M3, and then this is M4. Now if you look at this tiny branch which is coming out in the frontal view, it's a very tiny, and this is the anterior carotid artery. Look at this one. This is the internal carotid artery again. Two branches. One is the ophthalmic in the front, and two branches from the back of the artery, of the internal carotid. First one is the PCOM, and the second one is the anterior carotid artery. Look at the size. In this patient, this is the more important artery. Both are anyway important, but you can see that if I treat this aneurysm, okay, and I lose this, I may just get away with it, okay, because the PCOM is quite big. So something I've learned over time, that if you are in trouble, look at the PCOM and see whether they're in balance. Your point of view, you need to remember the one branch in the front is the ophthalmic, two branches in the back, one is the PCOM and one is the anterior carotid artery. So look at that. Again, you have the internal carotid artery, anterior cerebral artery, middle cerebral artery bifurcating here, and you can see that the anterior carotid artery, and I've called the aneurysm. So anterior carotid artery is the branch which comes from the posteriorly. It will be seen on a lateral view of the CTA. So then moving on from the anterior carotid artery, we are moving to the anterior circulation. So again, you can see internal carotid artery, middle cerebral artery, which is M1. You got the M2 here. And again, this is at the moment from endovascular point of view. This is where we are looking at. This is what we are targeting. M1, M2, A1, and then you can see A2, A3, and A4. Okay. So looking at the anterior cerebral artery, as we see, we have come up from here. We have come internal carotid, ophthalmic artery, PCOM, anterior carotid, taken the shape, and then you got the anterior cerebral artery. On the CTA is what you will see. You can move and you can play with it. You can see this is a view from the top, and you can see the anterior cerebral artery. The internal carotid artery comes here. Anterior cerebral artery turns medially, and it likes to join the other side through the ACOM. Well, towards the lateral side of the head, you're getting the middle cerebral artery. So if you look on the angiogram and the CTA, you can see that, now this is just a picture which I've taken from a book, but you can see that you have the brainstem here, and you got the basilar artery sitting in front of the brainstem. You got a clivus here, and you got a pituitary gland here. And then you can see, as you can see, the hypothalamus here, you get the anterior commissure here, but then you are seeing the corpus callosum. As you see the corpus callosum, you can see the anterior cerebral artery is going around the corpus callosum. And then it is the same thing, you can see the anterior cerebral artery, and you can see the pericallosal and the callosum marginal. So you don't need to know that. If you can identify the anterior cerebral artery, that would be very good enough from stroke point of view. Everybody's happy with that?
So just going to ask you that, so on the left slide, where your pointer is, that internal carotid artery, now going on the right side is the middle cerebral artery, so going up, this way.
Yes, that's right.
So that's almost equal to the size as ACA as well. So, yeah. Can that happen? You can't differentiate from the size.
No. So you can see this is a triangle.
Yeah.
This is a triangle.
Yeah.
On the lateral. Whether you do a CTA, you'll see the triangle. Whether you do that, you'll see the triangle. So that's the middle cerebral artery branches. So you can see there's a lot of overlap. Yeah. So one time, in the beginning when we started doing strokes, it was pretty different to us than when we were doing aneurysms. We used to do an anterior MCA, and then if it's an M2, on a frontal view, you just can't see it. I think, I can't see a stroke. And then when you do on a lateral view, you know that there is an absence of filling there. You know there is a vessel which is missing, and you have to find it. And sometimes because it's absent vessel, it's difficult. And then you have to go around on your angio to actually look for it. Sometimes you have to do a 3D for it. So it can be, this is a very, very important clue. In your practice, when you do a CTA, you need to start looking at it. That in the lateral, here is the middle cerebral artery. So you can see the anterior cerebral artery and you can see the middle cerebral artery here. So this is just again to show you that you have the internal carotid coming in. The both anterior cerebral artery are connected through the ACOG. And sometimes it's good to know that, because when we do occlusions and suppose we can't treat, sometimes it's nice to know where the collateral flow is coming. So you can estimate, every patient is, I think our treatment is evolving, and I think in time we'll be doing this as we do aneurysms, okay? We will change, our practice will change. We'll have to start, at the moment we are like plumbers, aren't we? Just go in, take the clot out, but in time, we'll have to start thinking, do we need to take clot out in every patient? Does it matter? Some people will have good collateral. So if you look at the middle cerebral artery here, you can see that all these perforators, which a lot of these we don't see on the CTA or an MRI, sometimes we don't see them. Okay? So remember, there are lots of lenticular striate perforators supplying your basal ganglia and the thalami here. Remember, they're all basal ganglia, thalami here. And these will all, we have to be very, very careful that and these are the problem. That's why when you do thrombectomy, after 2.5 hours also, you get a nice result for the cortical point, and you often land up with some ischemia in the basal ganglia. That's because the perforators are gone. So if you look at that, that's the ACOM, and then you can see, sometimes you might be lucky that you might be able to see this, but when you see this, it's bad news, because that means if this artery goes, you can land up with a big infarct. So recurrent artery of Hübner, again, if you get it, you land up with a bigger infarct. So when you look at strokes, and these are just some examples, as you can see here, and you can see here, I'm just going to, you can look at an anterior cerebral artery infarct. These are all non-stroke patients, but these are all aneurysms. Some of these strokes we have created. That's why we are very good at it at the moment, because we've been creating strokes for a while. And you can see that basilar artery, PCAs, internal carotid artery, middle cerebral arteries, and you can see that we have lost the supply here, okay, and you can see that you've got a stroke. So anyway, but the territory of anterior cerebral artery, what I'm trying to say is all in the front. So if you've got an ACA gone, you're going to get in the midline. And again, from a point of view of training, I draw a line which is like this, across the lateral ventricle. In the front is ACA, in the back is PCA, and all the one on the lateral view is MCA territory. And then you got a watershed. So very easy to remember that. MCA, you got a large herd of the two branches, and it goes horizontally, then it goes into the fissure, and then it will take a turn. You got a lot of lenticular striate branches, and you got 4 segments here. Again, from our point of view, we are looking at the moment M1 and M2. I'm really not sure whether we should be, what is the results of thrombectomy in M3 and M4. Don't think we are at the moment even considering that. At least not in UK. So there are other places they do it, not us. M1, as you can see, you got a perforators there. Then as you go, you can see so you got a medial lenticular striate, you got a lateral lenticular striate down branches. Then you got into the M2. Now you're getting into the Sylvian segment, and then you got into the M3, and then we got M4. Okay. So again, there are good devices which are coming in. But I have only once or twice gone in this region to take something out. I'm not really sure whether that was needed at all. But again, you can look at that. That's the circulovillus, basilar artery, circulovillus. Again, when you look at the territory of MCA, remember I said draw a line here, and you can see the middle cerebral artery territory is anything lateral to that line. Okay, so you draw a line on an axial section. You draw a line on the axial sections. So you got a lateral view. You got a PCA territory, ACA territory, MCA territory. So again, you can see internal carotid artery, middle cerebral artery, you got some perforators coming up, and you can see M1, M2, M3. So again, M1, M2, and then you got M3 here. Everybody's happy? Yeah, because these are the 2 main arteries that you are here for, aren't you? You need to just recognize that it's not that difficult, is it? Internal carotid artery, one goes, it divides like a butterfly, and then you got one wing on anterior cerebral, the other wing is the middle cerebral artery. And the territory is pretty much defined. And this is the beauty about arterial territories. Arteries have their own territories. Veins have no territories. Okay, we're not talking about veins today, but arteries keep their territories. So when you look at an angiogram, you got internal carotid artery coming in. What's that? MCA, brilliant. Yep. MCA. And which segment is that?
Cavernous. No, petrous.
Petrous comes here, takes a turn horizontally. This is the foramen lacerum where it is just at the top, and then it enters the Meckel's cave there, okay? And then it enters into the cavernous segment in here, takes a turn around it, goes up to the anterior clinoid, becomes the intracranial. So it's easy peasy. Okay? Anterior circulation, internal carotid artery, anterior cerebral artery, anterior cerebral artery. Look at the flow. You got a nice flow here. So you can imagine if you got a block here, and if the MCS flow, you still might get flow across. You always need to look at a flow coming from the top, flow coming from the bottom. Okay? Just the territories again. Anterior cerebral artery in the front, middle cerebral artery takes it. The posterior fossa is slightly different. Remember, you have got the pica, which is right in the middle, and then you got the anterior inferior cerebral artery, which are on the lateral part of the cerebellum, and then so these two you need to kind of remember that. And as you know, superior cerebellar artery takes the superior part of the cerebellum. So again, we'll go through this in detail again and again. But if you look at that, this is the top of the cerebellum. So and then you got a pica, you got a superior cerebellar artery. And the lateral part of the cerebellum is by the anterior inferior cerebral artery. If you look at anterior cerebral artery, draw a line, anterior cerebral artery, posterior cerebral artery, and then the MCA territory. You got lenticular stride. Another important thing, anterior carotid artery. Look at that. Posterior limb of the internal capsule, anterior carotid artery. So why is it important? It covers the posterior limb of the internal capsule. So important. So you need to make sure that it's open. When you look at that, draw a line. Anterior cerebral artery, posterior cerebral artery, middle cerebral artery. Joining anterior to posterior, remember I said that the first branch which comes out from the back is the PCOM, and this PCOM will then connect to your vertebral artery. And if you look at that, this is the circle of Willis, and you have the internal carotid artery. You got optic chiasm sitting in. As you can see, if you've got aneurysms here, you can have problems. But you got the anterior cerebral artery connecting. Both anterior cerebral artery connect through the ACOM. The basilar can connect through the PCOM, and one of the things I've found now from the posterior circulation, why people with basilar arteries, some of them can do better than some others, it all depends on your PCOM. I think if the top of the flow in the top of the basilar is maintained, you got a little bit more window period. It's just a hypothesis. I think that's what in a practice I've seen. We haven't got evidence in proof of that. You need more work to do to see whether that's real. But I have seen many times people who have 10 hours, 8 hours, 12 hours, good PCOMs makes a big difference. So if you look at that again, you got an patient who has been coiled, you got internal carotid artery, PCOM. Look at the anterior cerebral artery, look at the middle cerebral arteries. So we are coming down to the posterior circulation now. If you see the posterior circulation, you got the posterior inferior cerebral artery, superior cerebral artery, and the ICOM, which is the anterior inferior. Okay, so posterior circulation, smaller area, more problems. Smaller part, more compartmentalized, bigger problems. So when you look at the vertebral artery arises from the subclavian. It will come into the transverse foramen usually from C6. Sometimes it can come from C5. Sometimes it can come from C7. And then it enters around the foramen magnum, the transverse foramen. And then it comes up into along the C2. It goes between C2 and C1, goes on the arch of the C1 and enters the foramen magnum where it becomes intradural. So again you got 4 segments of the vertebral artery, and then you can see that the vertebral artery enters here and then it goes through the transverse foramen there, and then it comes out here C2. This is C1, C2, comes along the arch of the C1. This is where it becomes intradural. Why do I need to know? Because if you get dissections, you get a problem. If you dissect here, you get a subarachnoid hemorrhage. You dissect here, you go and get some aspirin. So again, it makes a difference. Now if you look at here, you got a vertebral arteries. They're both joining to form the basilar artery, and then the basilar artery will divide. You got one of the branches here is the pica, which is the posterior inferior cerebral artery. Then you got the ICA, which is the anterior inferior cerebral artery. Then you got the superior cerebral artery. You got smaller perforators coming off the brainstem, which you don't see. from the basilar, and then you got a posterior cerebral artery. So remember, vertebral artery, pica, ica, SCA, and then the PCA. So important branches again to look at every time you look at an angiogram. So again, basilar artery, the branches we already talked, various pontine branches, we don't see them. And that's the thing, you have to always remember, these are all the arteries. We don't see them on angiogram also. You're not going to see on a CT also. You don't see them. You don't have to worry about it. Okay, so this is from one of my teachers who had passed it on, and you can see that, and it's a nice slide that shows the basilar artery. It just gives you an idea that look at the basilar artery, look at the small vessels, look at that, look at the tiny vessels, look at the perforators from the basilar apex. Don't see anything of this, anything. Why? And then there's no white people with basilars, and when they get, if it is occluded, you get a significant problem with that. On the angiogram, this is again the vertebral artery coming in, you got a basilar artery. Look at the pica, which is the first branch, and this pica will take this turn upwards, it goes around the brainstem and then it divides, so that's the tonsillar loop here, and then you can divide, and it divides into hemispheric and other branch. So you basically, again, you're concentrating here, but mainly what you're looking at is you're looking at this area, you're looking at the basilar artery. So from stroke point of view, you're not going to be looking at pica because you don't treat pica strokes. What you're looking at is the basilar artery and the posterior cerebral artery, which is the main thing what you're looking for. So remember, again, you got a basilar artery, that's where the tentorium is, and you got a posterior cerebral artery. You can see the choroidal arteries, PCA arteries, as you see the branches. So on the CTA or a catheter angiogram, what do you look for? You're basically looking for vertebral artery, which is this is the C1, C2 part of the vertebral artery. It comes up, it takes that turn. This is where it's becoming intradural, and it's joining the other one. Can you see that? And you got the basilar artery, you got the PCA, you got the superior cerebral artery. So basilar artery, anterior, inferior, you're not seeing the pica here, and you can see the anterior. It's all you need to know, all from the stroke. How easy is that? It's not difficult, is it? You don't need a radiologist for that, do you? So. Okay, so when you look at the posterior cerebral artery, Dan is going to kill me at the end of this, aren't you, Dan? Yeah. Okay. Posterior cerebral artery. So, posterior cerebral artery, again, you see the segments, you got P1, P2, P3. We like radiologists to give lots of names to make it complicated so that you guys are going to keep asking me. But, that's the PCA, that's the PCA, that's the basilar artery, that's the integral artery. So P1, P2, P3, who cares for stroke? And look at that, you got a clot here in the basilar termination here, and you can see a clot here. You can see the clot, and then you can see the circulation here. You can see there's a posterior part of the temporal lobe can be involved in a posterior cerebral artery supply, as you can see here. And then you got a bit, so remember that bit of anterior posterior temporal lobe is supplied by the PCA. Anyway, perforating arteries, don't forget, always remember you got perforating arteries at the top of the MCA. Do not mess around with them. Basilar artery, again, there are perforators. And it's very important when I do thrombectomies, I need to look at these, okay? So I don't see them. When there's a clot, I don't see them. When I open the arteries, I want to see these coming out, okay? So that's very useful when I start seeing them. When you see clots here, you don't see anything. So circular village, quick word, circular village. Why is it important? Because all of us who are going to treat strokes, we need to understand the hemodynamics of the flow. We need to know how the flow is from the front to the back to the front. You got a basilar artery. So connection of the anterior circulation to the posterior circulation is the PCOM. Remember, is the PCOM. Connection between these two is the ACOM. And this can be very asymmetric. Okay? So if you look at that, that's a very good way of basilar artery coming in, internal carotid artery, ACOM, MCA. These can vary in patients, and there are different patterns, and that's why sometimes some people get away with it, some people don't get away with it. Sometimes some people Putin can get away with murder, can't he? So it's easy. So if you look at that, look at the internal carotid artery, anterior cerebral artery, middle cerebral artery, internal carotid artery. So you need to learn to reconstruct these on your workstations, okay, or wherever you go to Siemens or Philips, and if you guys don't get your boys to train you, call me. I will come and train you on your workstations. It's easy. That's what Tommy Anderson did. Tommy Anderson in Stockholm, what did he do? He went to the centers of the stroke physicians and train them on their workstations to look at the CTAs. It's easy. It'll take me 1 hour, to train you guys on that. An internal carotid artery, middle cerebral artery, M1, and you can see the perforators here, and you can reconstruct. You can see internal carotid artery, middle cerebral artery. You can see anterior cerebral artery here, anterior cerebral artery, ACOM. You can see the lateral, I've reconstructed here. You can see the pericallosal, the callosomarginal. You can see everything. Basilar artery, superior cerebral artery, P1. Right superior cerebral, left superior cerebral, P1. And you can reconstruct all this. Come on, you're all consultant, you can easily do this. And in basilar artery, vertebral artery. So pretty much straight. There are variants which sometimes you have to know, and you get a persistent trigeminal artery, which is, again, it's not going to make any difference from our treatment point. So I think I'm going to stop. Have I got time for one case to show? I'll stop, because I think we've got one case. This is a Bradford case, and this was the boy on the telly. Okay? So this boy was, I think there are a lot of people, and I'm very grateful for Dan, because he saved this boy, not me. Because I would come in. I got called by Dan in the middle of night, okay, for his boy from Bradford, which was nice because the radiologist there made an attempt to contact the guys here. And the boy had a 4-year-old boy presenting with a stroke. How many of you have seen it? 4-year-old. Okay? So 4-year-old boy, you can see that vertebral artery, and you can see that. And by the time he came here, he was intubated. Okay? And you can see there is a clot here, and you can see the clot. And then I've used the solitary here, and I've taken the clot out, and you can see that. This is not difficult. This is vertebral artery, the basilar is clot. That's one artery you need to know. And the other artery is internal carotid with MCA and ACA. Not different. So I can see that, and you can see that I've opened up. There was no flow here, and there's no flow here. Okay? This is another one, same story. Basilar artery. Okay? I moved this. This is a little bit complicated, so I will take that. This is a professor, and this is Dr. Mentes, I call it Korea. But this was a professor in Leeds University, came in, was referred to us. He had been in the cardiology clinic, right? And he was not, we couldn't thrombolize him. NIHs of 18, CT and CTA. So, when the stroke physician makes an attempt to call us, it makes a big difference. Look at that. He's got an MCA clot. He comes in, you got a CTA, you can see the internal carotid artery. You can see the internal carotid artery. You see the clot there. And this CTA was already done, and I just had to look at it and say, it looked good. You look at the aspect score, collateral score, which we'll learn, and look at that. Internal carotid artery comes here, sudden block, no collateral here, anterior temporal branch is here, 10 minutes. Okay, one shot. This was done in the conscious. He was NIHS 2 within a few hours. Okay, and then you got a flow completely. Post-op, you got a CT here, which is tiny flow. Great job, and I think I was very pleased, and he's done very well. So thank you. Okay, thank you very much. Any questions? Okay. Thank you.